Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project. Thank you all for joining us today and our friends at Generations for hosting today's session, Screening for Colorectal Cancer. 45 is the new 50 with Dr. Nelson. Dr. Nelson is a practicing general and colon and rectal surgeon at Asante Three Rivers Medical Center in Grant Pass, Oregon. He is currently serving as Chief of Staff and Medical Director for Asante Physician Partners, 15 specialty clinics. He's been in practice for 15 years. He is a frequent lecturer for the General Surgery Review Board and has served on the Clinical Practice Guideline Committee for the American Society of Colon and Rectal Surgeons. And we're just so very thankful to have him as a MAVEN Project volunteer and as our speaker today. So Dr. Nelson, when you're ready, please begin.
All right, I will. Well, thank you. Thank you very much. It's great to be here with you today, and I appreciate the opportunity to speak on a topic that is near and dear to my heart, which is screening for colon and rectal cancer. And just a few years ago, the guidelines changed. So 45 is the new 50, and we're still trying to spread the word to let people know that that's happened and how important it is to be screened. And so I'm grateful to speak on this subject today. I'm very happy to have any questions as we go along, as was pointed out. So I do not have any disclosures. And so I have not been influenced by anything other than just our guidelines and my desire to make sure that we screen as many people as possible and prevent colon cancer. And as was noted earlier, this is an accredited presentation, and so there is CME, and so you can get that for yourselves as you participate and hopefully learn something today. But these are the things that I hope we take away from the presentation. The first is that we understand how to place our patients in a risk category. Or assigning a risk category to our patients helps to know what's the best way to screen them. And so we'll talk a little bit about that today. We do want to talk about the different modalities that we have in order to screen individuals for colon and rectal cancer, and then to select the appropriate screening modality for each of the patients that you see. So that's our goals. And so let's jump right in. So this is the 2023 National Cancer Institute SEER data, and I just put this on there just so that we all have an understanding of what we're facing as we talk about cancer in the United States, and specifically the big four cancers that we deal with. Breast and prostate cancer, the most common cancers that we see, and so those purple lines just really indicate the incidence of the cancer over the 2023 year. You can see almost 300,000 cancers, or 300,000 cancers for both of those. Lung cancer comes in third, and then colon and rectal cancer is fourth. And the green bars indicate how many people pass away from the disease. And we seem to do very well with breast and prostate cancer. Thankfully, lung cancer is still a huge concern and still kills a lot of individuals in our country. And then colon and rectal cancer is the second most common cause of death. And I think that's sad because colon and rectal cancer is completely preventable. Early screening, early detection really prevents people from developing colon cancer, and it's just that important. So we have seen good trends in the incidence of colon and rectal cancer, and so this graph just really shows the progress that's been made over the last several decades as we have really tried hard to institute screening modalities throughout our country. You can see that back in 1992, the rate per 100,000 was 57, and in 2020, we've been able to bring that all the way down to 33. And so there has been significant improvement in just the incidence of colon and rectal cancer, and we chalk that up to people being screened early. I do think that one of the important things to understand is that everyone is at risk for colon and rectal cancer. And in fact, when we look at the data, 4% of men and women will be diagnosed with colon and rectal cancer at some point in time in their lifetime. And 94% of all of these cancers are diagnosed after the age of 45. And that is one of the indications or the reasons why that number has dropped from 50 to 45, is because we are finding more cancers in younger patients. So again, this is important. This is an important topic to have, or a conversation to have with your patients as we talk about preventing colon and rectal cancer. We like to talk about the risk factors for the development of colon and rectal cancer, and this list is not all-inclusive, but certainly these are the major factors that we look for in individuals that may increase their risk. Age obviously is one. The older we become, the higher risk we have for developing any cancers, but certainly colon and rectal cancer. Certain subpopulations in our country are at higher risk: Black adults, American Indians, and Alaskan Natives. They do seem to carry a higher risk for the development of colon and rectal polyps. Anyone who has a family history of colon and rectal cancer, and this is even outside of the inherited syndromes that people can have, like FAP or HMPCC. If you have a first-degree family member, that does put you in a higher risk category, and we'll talk a little bit more about that in just a minute. Men, obesity, diabetes, smoking, unhealthy alcohol use, all of these are contributing factors. And we do know that there may be some benefits to a high-fiber diet, fruits and vegetables, those types of things. But really, these are the risk factors that we know of that serve our populations poorly as far as their risk factors go. So let's talk really about where we start. You know, when you're sitting down with a patient in the clinic and you're looking at them and we're thinking about screening tests, we want to look at the individual and assign them a risk category. And there are 3 risk categories when it comes to colon and rectal cancer. So there's average risk, there's an increased risk, and then there's a genetic risk of cancer. And so I'll start with the other 2 risk, increased risk and genetic risk first, just because if you don't fall into those 2 categories, then you're just an average risk individual. You have 4% chance of developing colon and rectal cancer over your lifetime, and that becomes a little bit easier. But individuals who have an increased risk are those who have a first-degree family member. And so obtaining a family history to the best of our ability, and I recognize that not everybody knows their family history very well, but understanding who else in the family may have colon cancer or rectal cancer and or polyps is an important piece of the equation. And so really diving into that family history is key as we're talking about risk factors. Other risk factors include a history of colon polyps or colon cancer. And so if an individual's already had a colonoscopy in the past and they've been found to have adenomatous polyps, that does place them at an increased risk, and so we assign them a different risk category. Patients who have inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, are also considered at increased risk or higher risk for colon and rectal cancer and fall outside of our average risk category. And then there are some more unusual diseases that we may not see all the time, but cystic fibrosis, those individuals are also considered to be at increased risk, and so they fall out of our average risk group. There's our genetic risk population, and this is more rare. I see hundreds, if not thousands, of patients for colon cancer, and really very few of them fall into this genetic risk category. But these include such syndromes as HMPCC or Lynch syndrome, the polyposis syndrome such as FAP or MUTYH associated polyposis, Peutz-Jeghers, juvenile polyposis. And we won't get into any of those details today, but typically we see a number of patients who have many family members that have developed colon and rectal cancer and or they have younger age cancers in their family. And so those are, again, part of that family history portion of the H&P that we do that asks a lot of these questions.
There is a question.
Sure.
Is celiac disease a risk factor for colorectal cancer?
That's a great question. Celiac disease is not a risk factor for colon and rectal cancer that we know of. I don't know how extensively it's been studied, but that is not something that we generally assign with colon and rectal cancer. Celiac disease affects the small intestine, not necessarily the large intestine. A diagnosis is typically made with biopsies of the duodenum or the proximal small bowel. It doesn't have to do, or we don't know of any real risk factors associated with colon cancer, even though it can cause other bowel issues. So, but that's a great question. And so if you don't have an increased risk, if you don't have a genetic risk, then you're just average risk, which is actually really good, because that gives us some other modalities to screen you. And so again, those are, I think, the big takeaway messages as we start this talk is we want to assign a risk category to our patients, and family history, a history of colon polyps or inflammatory bowel disease puts people in a different risk category. And typically everybody else falls into an average risk category. So if you do have an average risk patient, then what do we do? What can we do? What do we have options to recommend to them? And that's what we want to talk about today. So this is for just probably a majority of the patients that we see. And we'll start first with just the stool test. So we can have the patient submit a stool sample. We can check that for lots of different things, and that is a very good way to screen for colon and rectal cancer. And I'll talk about the three most common. We have the FIT test, we have fecal occult blood testing, and then we have the stool DNA, which is a combination of FIT and DNA testing. And I think that's commercially the Cologuard test that you may or may not have heard of. Those are the three most common stool tests that we use to try to screen individuals for colon cancer, and they work best if they're done on a regular basis. This is something that needs to be done, and the real trick to doing stool testing is to make sure that people are staying up to date with the test and doing it on a every year or every 2-year, every 3-year basis, depending on which test you're using. FIT testing detects blood using antibodies, and it's a very sensitive, very specific test. It does a nice job at just letting you know, yes, there's blood there. And you can use fecal occult blood testing, but that just detects heme, and there's a lot of false positives with that. And that's because if individuals are eating meat, you can have a positive test because it's detecting heme from any source, not just from the individual. And the best test really is probably our stool DNA FIT test, and that's where we're also checking for changes within the DNA structure that may indicate a polyp and or a cancer. You can see there, though, that the costs vary quite a bit. FIT testing and fecal occult blood testing is very inexpensive, relatively speaking. The Cologuard test, while it's an excellent test, is much more expensive. And I guess the benefits are you don't have to do the time intervals as much. If you think about everyone recommending stool testing, though, for example, as a group like yourselves, it is much better, I think, in my opinion, to have everybody doing the same test so that you can develop a rhythm of it needs to be every 2 years because we all use the same test. If some people are using a Cologuard and some people are using fecal occult blood and some people are using FIT, it can be very confusing for the patients and the providers if you're sharing patients to know, well, which one did you do and are you due again? And so really the operational piece of stool testing is really probably the critical component. It's a very easy test to do, and most patients don't complain about doing this as opposed to drinking a bowel prep, which we'll talk about in a minute. If any of those tests come back positive, you do need to have a colonoscopy, and that's because there is obviously something going on and we want to evaluate that more fully. But stool testing is a very simple, easy way to screen people for colon cancer, and making sure that you're doing it on an annual or every other year or every third year basis is important to make sure that you can really prevent colon cancers for individuals. It shouldn't just be used as a spot test, though it can be. There are radiographic tests for average risk patients as well. There's a virtual colonoscopy, which is a CT scan, which is a 3D rendering of the colon. It does let you fly through the colon and you can see the mucosa virtually, if you will. It's a pretty cool technology. It isn't as wonderful as it may seem because patients still need to do a bowel prep, which is the worst part for everyone in getting things done. If they do see something, then the patient should have a colonoscopy, which either should be done the same day or they have to redo the bowel prep and come back. And so that can be frustrating for individuals. And there's no anesthesia, and you have to pump the individual full of gas. So they're still sticking a tube up inside and inflating the colon while they do the procedure. And so it can still be a little bit uncomfortable. And so virtual colonoscopy is possible, and maybe in some cases it's recommended if you have a colon that you just can't get through with a scope. But by and large, I think virtual colonoscopies have kind of fallen out of favor just because you're still having to do a lot of things to people. And it may sound cool, but it's still invasive at some degree. Back in the old days, barium enemas were also another modality that we could use to evaluate the colon, and that too has kind of fallen out of favor. They're very uncomfortable tests, and they typically needed to be combined with stool testing. And really, if you were going to pal prep somebody and then pump them full of something else, you might as well just do a colonoscopy. It's a more comfortable procedure in the long run. And so barium enema has kind of fallen out of favor as far as a screening test. It still has its use for other issues, but not for screening. The next way that average risk individuals can be evaluated is endoscopically. You can do a flexible sigmoidoscopy if it's combined with a stool test. Here I practice in Oregon, but I grew up in California. Kaiser dominates the market here in California, and for years, Kaiser did a very aggressive program of FIT testing or fecal occult blood testing in combination with flexible sigmoidoscopy. They did publish their data, and they did see a significant reduction in colon cancers. And so in a good program where people are doing that on a regular basis, that can be a very good screening modality for a population. It's never made a lot of sense to me personally to only go halfway through the colon and then leave the other half unchecked. And so for myself, if you were going to do half the colonoscopy, you might as well just go all the way. But they would do this without sedation. They could do it a little bit cheaper. And so in their mind, that was a good diagnostic screening modality for their population. Really, I think the gold standard, though, is a flexible colonoscopy. It combines both the ability to diagnose but also treat simultaneously. And so we are screening individuals for polyps. If you find those can be removed. And that really is what we're looking for with all of these other tests is, growths that are abnormal that need to be removed. And so colonoscopies are very good. They are the most invasive, obviously. People do have to do a bowel prep. We do use sedation for that, which makes the procedure more comfortable. But it is an invasive procedure, and we just need to think about all the ramifications as we do that. So, which are right here. So, how effective is screening when we look at each of these modalities? Do we really save lives, and which one saves more lives, and which one has more potential complications? And the U.S. Preventative Service Task Force statement really, I think, lays this out very well. You can see that the first 3 or 4 lines there are stool testing. So you have fecal occult blood testing or FIT testing, DNA testing, and you can see that life years gained per 1,000 people, we do see an increase as we use those tools. People do have better outcomes. Lives saved per 1,000. You can see that we're saving about 20 to 23 lives as we use those screening modalities, and there's very little harm as we do that. As we go down the list, though, you can see the other screening modalities: CT colonography, flexible sigmoidoscopy, and FIT testing, and then colonoscopy at the bottom. And obviously, colonoscopy is the best. It does save more lives. It adds more life years to people because we are detecting more. We are doing a better job. However, you can see on the right side that it is a little bit more risky. More harm is done. You can still miss things with colonoscopies, and there are perforations and bleeding complications that can occur. And so all of this just needs to be taken into consideration as we're talking to an individual who has average risk about what is the best way for that person to be screened, and what are they willing to do? And I think those are the most important questions. So what do we do if we have someone who is at increased risk? Let's say we have a patient with a very strong family history. Their mother or father died of colon or rectal cancer at an early age, or even an older age. They are now in an increased risk category. And there's really only one option, and that is a colonoscopy. Because they're at higher risk for the development of polyps, we recommend the best modality to screen them, and that is a colonoscopy. And so as people undergo colonoscopies and we do find polyps, which is not uncommon, I would say probably 40 or 50% of people that I screen do have polyps. We then make recommendations for those individuals to come back sooner than the 10 years. And so if we do a screening colonoscopy on an average risk individual and we don't find anything, 10 years off for good behavior, we send them home. That's great. They don't have to think about it anymore. They don't need to do FIT testing. They don't need to do the other stool tests. The colonoscopy should cover them for 10 years and they don't have to think about it. And that is one of the additional benefits. However, if they do have polyps, we do bring them back sooner, and it depends on the number of polyps, the size of the polyps, and the histology of the polyp that determines when an individual should come back. And really, as a surgeon, as someone who does a lot of colonoscopies, I have always felt that it's the individual who does a colonoscopy is the best person to determine when someone needs to come back. They understand how well they saw all of the tissue. They know how well the bowel prep was. They know what the polyps look like and how many. And so it really doesn't fall on a family practitioner or a primary care provider to tell an individual when they should be coming back after a colonoscopy. That responsibility falls to the individual who did it, and those recommendations should be made by them in their chart or in the note. And then really, I feel it's our responsibility to make sure that we call the patient and get them back in because we're the ones who are now responsible for their screening moving forward. Patients who have a history of inflammatory bowel disease should be having colonoscopies every 3 years, and usually good gastroenterologists are on top of that because there is a significant increased risk for the development of colon and rectal cancer the longer they have inflammatory bowel disease. And we use 8 years as the kind of the line of demarcation, but certainly if they have active disease, we will be watching them much more closely. And then lastly is family history. If you have a first-degree family member that has colon and rectal cancer, you get to be screened every 5 years, even if we don't find anything. And that is because there is that increased risk component to you. And so if your mom or dad has had colon and rectal cancer, or any of your children, any first-degree family member, you should be coming in and being screened every 5 years by a colonoscopy. Lastly is just genetic risk patients. And again, this is very easy. If you have a genetic inherited polyposis syndrome, you just need to have a colonoscopy as part of your screening and or honestly surgery. And so these are more challenging topics that we have with our patients if they are diagnosed with one of these genetic risk syndromes. And the reason for that is because their risk of getting cancer is up to 100%. If you have FAP, which is familial adenomatous polyposis syndrome, your risk of developing colon cancer is 100%, and usually it's by the time you're 30. And so these syndromes run in family. These individuals have thousands of colon polyps. And so we recommend a colectomy. We remove all of the colon and the rectum. We give them a J pouch, and we usually do that around 18 to 20. Thankfully, genetic testing is becoming much more easy to obtain nowadays, and so we can check all of the family members pretty quickly for these types of syndromes, and we certainly recommend that we do that if there's a suspicion. HNPCC is another. This is Lynch syndrome. These individuals typically will develop right-sided colon cancers at a younger age, usually around age 40. And so we do recommend surgery for them at some point in time. It can be a little bit more variable. I have a number of patients with HNPCC who are not interested in having a major surgery, which I don't blame them for. And so we do annual colonoscopies, and almost every time they have multiple colon polyps, it is impressive how quickly they grow. And so there is just a significant risk for developing colon cancer in these individuals, and they are screened differently. I guess surveillance would be a better term than screening. We're no longer screening them. So lastly, when do we stop screening? This is always a great question. You know, when do we tell people, look, you don't have to do this anymore? And the guidelines are pretty clear. We gain few additional life years after the age of 75. And so we recommend screening individuals up to age 75. And then for me, it becomes a little bit more personal. I have a number of 75-year-olds who take excellent care of themselves. They're out walking every day. They're still very active. And I look at them and say, you know what, you can probably get to 100. So maybe we do want to continue to screen you for colon and rectal cancer. And then I have 65-year-olds that come in on oxygen, and I'm like, you know what? you're great, no more, everything's fine. And so 75 is kind of a soft cutoff for screening. And I think we look at each individual and we can make it a determination. But after 75, people usually have to be asking me to do it. I'm not typically recommending that we go forward and keep screening people. After 86 or really 85, there's no reason to be screening individuals. If they have been appropriately screened up to that point in time, we can say, you know what, you're good. And that's really because a polyp to cancer transformation on average is about 10 years. And so there's just very little benefit to continuing to screen people after 75 and certainly 85. And so those are the recommended cutoffs. And again, it can be a little flexible at the earlier ages if you have healthy patients, but by and large, 75 is the time when we say, thank you, you've done everything you need to, and we can move on. So just to wrap up, our goal obviously is to prevent colon cancer. And again, as we pointed out, it still remains the third or the second leading cause of cancer death in the United States after lung cancer, and it is completely preventable. And so just hammering that point home to our patients that we can prevent this if we will just screen you. And there again is lots of different ways to screen people. So if they don't want to have a colonoscopy, let's pick a different modality. Even if they don't fit into the right risk category, screening is just that important. And so we want to assess the risk of our patient, whether they're an average risk, increased risk, or have a genetic risk for colon and rectal cancer. We then pick the modality that they are willing to do to be screened, and then we stick to it and we make sure that they're getting screened as often as possible. And so really the take-home message outside of all of that is 45 is the new 50. And so we are encouraging younger patients to come in and be screened because we are finding cancers at a younger age. So I think that's it. I appreciate your time. I'm very happy to have the opportunity to come and speak about an important topic. At least in my mind, I am happy to open it up to questions. So
Thank you. That was great. I was messaging in the background that everybody on MAVEN missed a great talk. But we do have a few questions. And just a reminder, if you have questions, put them in the Q&A box or use the raise hand feature. I always say use the raise hand feature when there's big words. I stumble over those. Would a patient with only a few risk factors, such as ethnicity and obesity, be considered average risk or increased risk?
that's a great question, and I probably should have clarified that. Those are factors that we know do increase people's risk, but we don't use those as increased risk categories, if that makes sense. So they would still be an average risk individual. We just know that those either inherited components or diet or whatever, that increases someone's risk for developing colon polyps and subsequently colon cancer, but we don't screen them differently based on those factors, if that makes sense. So
Do you have any advice for prep for patients?
I do. The best preps I have found are the split dose preps. So this is a prep that you drink at 2 separate times. So for most of our patients, we'll have them drink at about 6 or 7 p.m. the day before. And then depending on the time of the procedure, they will then drink the second bottle of prep about 4 hours before the procedure. And what that does is it allows us to clean out the colon much better. And so a split dose prep is preferable over the big, go lightly, the big gallon jug, or just drinking something at one point in time. So anyway, split dose preps, those are our favorite.
Great. At what age would you screen a patient at increased risk?
So another great question. Let's say that I have someone who comes in to see me and their parent developed colon and rectal cancer at, say, age 40, which would be a little bit more unusual, but certainly not unheard of. Then that individual should have a colonoscopy because they're at increased risk now 10 years prior to the age at which the individual, their family member, was diagnosed. So if mom or dad was diagnosed at 40, then that individual should be screened at 30. And so that's a different age just based on that family history that you take. So that's a great question.
Great. Can you please specify how you choose who with polyps should come back in 1 year, in 3 years, and in 5 years? There's a lot of different recommendations out there.
Yeah, so it's based on the number of polyps, and so when we start having more than 3 polyps, that raises red flags for me. The size of the polyp, so any polyp that's over a centimeter, and then also the pathology report. So if I have a report that comes back that says this polyp was an adenomatous polyp, that's not as concerning as, say, an adenomatous polyp with high-grade dysplasia. And so if we see that the features of the polyp are advancing towards a malignancy, then that again is another red flag for us. So if I have a patient, let's say, that has 5 colon polyps and one of them comes back with high-grade dysplasia, I'm bringing that individual back in 1 year because I want to keep a close eye on them. And they've proven that they make bad polyps and they make a number of polyps. And so we want to watch closely. If I have someone that just has 5 polyps and they're all benign, I would bring them back in 3 years and say, okay, you have a lot of polyps. We are going to watch you a little bit more closely, but none of the polyps were of any major concern, but just the fact that you have so many, we're going to bring them back. There are recommendations that are all over the board. And so I admit that it is a little bit more nuanced. You can go to the American Society of Gastroenterology and they have their recommendations, and you go to the American Society of Colorectal Surgeons and they have their modality, and Family Practice has their recommendations. And one of the challenges with the screening conversations is that you can read lots of different things from different societies. So at that stage, it does become a little bit more confusing, but I think everybody is in agreement. More polyps, more advanced pathology, shorter window for screening. So.
Thank you. Just answer that one. Why would a person who follows bowel prep instructions exactly still have a poor response?
Um, that's a great question that I get to answer a lot. Not everyone's colon runs at the same speed. And I get to have conversations about bowel transit time every day with my patients. There are just some people that have a slower colon. It just runs slower and they don't always prep as well as other people. I would say about 5% of our patients will come in, and I believe them when they say they did the prep just like they were supposed to, and their prep is not good, and we have to do a 2-day prep where now they're prepping for a second or an extra day, which can be even more painful than just prepping for a first day. But some colons just run slower. They do not flush out as well. They don't have the same response. I don't know that I have a great reason for that, or even really who or why that happens. But we do know that about 5% of our patients that we see have a slower motility and they just don't get prepped as well. So a 2-day prep would then be recommended, which is twice as painful as doing it one time.
Fair. What do you use for a split prep exactly?
Um, well, again, I'm not trying to throw trade names out, but we use SUPrep as our preferential prep of choice. It is a little bit more expensive, but I have found that to be very effective. So that's one of the preps. There are newer preps that are coming on the market all the time from different companies. And it's really just that split dose that I think is the most important. In fact, if we take a big jug of Go Lightly, I now have the patients just drink half of it and then drink the other half later, because it's the timing of when you're prepping and cleaning things out that is probably more important than the volume of things that you're drinking. It's just getting that colon extra clean and spitting everything out. So, but we use SUPrep. It works really well, and that's what we've kind of gravitated towards.
Okay, great. Could you please speak to how certain foods or medications may affect stool testing?
Yes, so that's really more for fecal occult blood testing than the FIT test. And that's because the technology, if you will, has advanced enough where we use antibodies now to detect blood. And so those antibodies can be quite specific for for just human blood. Fecal occult blood testing is just that guaiac test, and it's really just trying to detect the presence of heme. And so individuals who eat a lot of red meat can have a false positive test. Even some acidic foods have been noted to give a false positive on the stool guaiac test. And so if you're looking at testing a population or your patients, fecal occult blood testing is probably the worst test to use in the sense that it has a lot of false positives. So FIT testing, which is from a price perspective about equivalent, would be a much better test because of that. The other thing that I would also tell you is that these tests need to be done without an examination. So if you're seeing someone in the office and you do a rectal exam and take some stool and wipe it on the card and send it off, which is what we used to do when I was in medical school, that invalidates the screening portion because there is a risk that you can tear something, a hemorrhoid, or have some blood from the exam. And so that's another component to this, is it, and if a patient is bleeding all the time, and so we use that as a screening test to see if they have cancer. The test was just going to come back with, a positive result. And so, again, when we talk about risk and screening and the reasons to use some of these stool tests, we have to keep in mind that they are designed just for screening purposes. We can use them to detect blood, obviously, but if someone's bleeding, you're going to get a false positive test that doesn't help us make a decision. So, but I hope that helps. Fecal occult blood testing is probably not the best way to screen people in the long run because there's
Okay,
just a lot of false positives.
good to know. Next question. Is it okay to dilute the bowel prep with, say, Gatorade to make it more palatable?
Yeah, you can drink whatever you want outside of alcohol. I tell my patients, just water, Gatorade, any clear liquid is fine. Suprep, again, I'm not trying to promote one product. They've now come out with pills. And so you can take 24 pills, you take 12 pills and 12 pills, and you can drink whatever you want with that. But yeah, Gatorade's fine. Any clear liquid is fine, just plenty of fluids.
For patients with known hemorrhoids, do you recommend utilizing colonoscopy, or are there cases in which stool tests could be recommended?
That's a great question. I think it depends on how much people are bleeding. So if hemorrhoids bleed every once in a while, I think the stool test is probably fine. We just have to keep that in the back of our mind that if we get a positive result, we don't really know if it's a hemorrhoid bleeding or something else. And so you're still obligated to do a colonoscopy. So if patients are bleeding frequently, doing the stool test may not be helpful in that regard because it's going to come back positive. And then you're stuck wondering, well, is it hemorrhoid bleeding or is it something else? And if people come in with symptoms, then that's not a screening examination conversation anymore. If people come in bleeding all the time, well, they need a colonoscopy usually because they're having some symptoms. Something's happening and we're sorting that out. So again, I do think we have to separate the conversation between symptoms that people have versus screening. And what we've just been talking about today is no symptoms, average risk, increased risk. We're just screening individuals for colon cancer. They don't have any other problems versus people who come in and are bleeding or having some symptom. Then, if we're talking about, well, colonoscopy at that stage, then that's a different conversation. So.
Great. I don't see any questions right now, but we're still going to pause. We have plenty of time, so please feel free to put them in the chat, the Q&A, or raise your hand. But while we're waiting and I'm stalling, just a quick reminder about our CME survey. It's really exciting that we are now offering in-time CME certificates instead of the awful summary certificate after the end of the calendar year. But just a reminder that you have to get a couple things correct to receive the certificate immediately. So your licensure, please make sure that you get your correct licensure. Could actually deactivate your account if you select like other or one of our non-platform supported licensures. The correct date, so today is April 10th, and the correct volunteer, so today is Dr. Scott Nelson. Please be careful when you go on the CME survey today. We also have a Dr. Benjamin Nelson, different guy, he's a pulmonologist. So make sure it's Dr. Scott Nelson that you select. For those of you who attended the morning session and you did not receive your certificate, There's a couple issues. You'll receive them shortly as soon as I make the changes. And I thought that would stall long enough for questions. I don't see, oh, Kim, I see that your hand is raised, so please give me 1 second. I'm going to unmute you. All right, you have the ability to talk now.
Hi, this is Kim, and I used to work in a community health center, and I had an account with you guys, and I would love to continue to learn, but I moved employment to a more like a private sector, and I don't have an account with you guys anymore, but I do get these emails, and I like to participate in the CMEs, but I used to have that platform where I would get like a teaching a mentor session or something like that, and I just don't have that anymore, and I would like to continue to learn. Does Maven will allow me to be able to do that, to get an account?
We can talk offline. I can connect you with our ClinOps team, which would be able to answer your questions. I mean, I'm of a mind to say, yeah, let everybody join, but they'll actually be able to answer your question.
Yeah.
All right.
How can we connect?
I have your name written down. I will send you an email after the session.
Okay, great. Great.
Thanks
Thank
so
you so
much.
much.
All right. Well,
I am looking through the chat, and let me just make a few comments. So one of the questions was any advice for prep for patients? And we talked a little bit about split dose prep, but I like the frosty anus like a cake with Desitin. So that's actually very good advice. I would actually recommend Calmoseptine, which is one of my favorite ointments for individuals who have perianal irritation, itching, and/or rash. So Calmoseptine may be something that actually is more helpful. Excuse me. And then as people are drinking the prep, I think ice cold water or liquid can be helpful. You can use a straw. The other thing that I would recommend is when you do a split dose prep, they recommend that you drink the entire thing within several minutes. And I have found from personal experience, if you drink it a little slower, if you take it over about an hour to an hour and a half, it actually causes a lot less nausea, and it still has the same effectiveness. So those are just little simple tricks that I would recommend for folks as they're getting through a bowel prep. That it is really there's just some nuances to that. So anyway, I like the rest of those ideas, so those are good.
Thank you. All right. I do not see any other questions, so I'm going to assume we're all experts now and we are good to go. So Dr. Nelson, thank you so much for joining us today. I know it's a little bit early for you, but we really, really appreciate you being here.
Yep,
And
thank you for having me.
all right, and thank you everybody for joining us. Have a great day.